Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
This content offers an overview of the key considerations in the toxicology and management of hypoglycemic agents, with a focus on metformin-associated lactic acidosis, hypoglycemia induced by sulfonylureas, and insulin overdose. It explains the pharmacology and mechanisms of action of these drugs, along with their associated adverse effects and toxicities. One important topic is the challenging diagnosis and the varied clinical presentation of metformin-associated lactic acidosis. The discussion includes its causes, risk factors, prognosis, and strategies for treatment. Another significant area involves understanding the mechanisms behind hypoglycemia caused by sulfonylureas. Factors that contribute to its prolonged and delayed onset are examined, as well as the complex interactions of dextrose administration and the role of octreotide in managing rebound hypoglycemia. The content also addresses the risks associated with insulin overdose, emphasizing the potential for severe and prolonged hypoglycemia. It highlights the importance of immediate correction and strategies to prevent recurrence. Additionally, it covers the diagnostic utility of C-peptide levels in differentiating between various causes of hypoglycemia, such as exogenous insulin administration, insulin-producing tumors, and overdose of sulfonylureas. This content covers 10 key learning objectives. First, it explains the mechanism of action of metformin and its various effects on glucose metabolism. It also identifies the key risk factors and the challenging clinical presentation of metformin-associated lactic acidosis. Additionally, the content summarizes the treatment recommendations for this condition, including the role of extracorporeal treatment methods. Furthermore, the objectives include an explanation of how sulfonylureas induce hypoglycemia by stimulating insulin release from pancreatic beta cells. It discusses factors that contribute to the prolonged and delayed onset of hypoglycemia caused by sulfonylureas. The material also explores the complex interaction between dextrose administration and rebound hypoglycemia in cases of sulfonylurea overdose, highlighting the role of octreotide in management. The objectives outline the recommended dosing and administration considerations for octreotide in treating hypoglycemia induced by sulfonylureas. Additionally, the content emphasizes the risks and characteristics of insulin overdose, including the potential for severe and prolonged hypoglycemia. It details strategies for immediate and ongoing management of insulin overdose and explains the usefulness of C-peptide levels in distinguishing between hypoglycemia caused by exogenous insulin, endogenous insulin production such as insulinoma, and sulfonylurea-induced hypoglycemia. Instead of using the terms metformin-associated lactic acidosis or metformin-induced metabolic acidosis, it is more accurate to describe this condition as metabolic acidosis with an elevated lactate concentration. This is because elevated lactate levels can occur in various diseases and may not always be associated with acidosis. Additionally, the production of lactic acid does not necessarily lead to an increase in hydrogen ion concentration unless oxidative metabolism is also impaired. When oxidative metabolism is impaired, It results in increased hydrogen ion production through the hydrolysis of adenosine triphosphate, which contributes to the development of acidosis. Metformin is a widely used medication with decades of clinical experience. Despite its extensive use, the precise mechanism of its action is not entirely straightforward. While many sources describe the mechanism as not fully understood, reliable toxicology references provide a more detailed explanation. Metformin primarily inhibits glucose production in the liver, a process known as gluconeogenesis. It achieves this through various mechanisms, including inhibiting mitochondrial glycerophosphate dehydrogenase and suppressing signaling pathways activated by the hormone glucagon. Additionally, metformin enhances glucose uptake in peripheral tissues, especially skeletal muscles, by inhibiting mitochondrial complex I. This inhibition activates the enzyme adenosine monophosphate activated protein kinase, which promotes increased cellular glucose uptake. The medication also decreases the oxidation of fatty acids and increases the utilization of glucose within the intestines. Moreover, metformin can alter the composition of intestinal microbiota, which may contribute to its effects. Furthermore, it raises the levels of and the sensitivity to a hormone called glucagon-like peptide 1. This hormone is released in response to food intake and plays a vital role in blood sugar regulation by enhancing insulin release, delaying stomach emptying, and reducing food intake. MALA, or metformin-associated lactic acidosis, presents a diagnostic challenge because it can be difficult to identify through physical examination alone without a known history of metformin use. Early symptoms are often nonspecific and may include abdominal pain, nausea, vomiting, general malaise, muscle pain, and dizziness. It is important to note that these symptoms are also common adverse effects of metformin therapy and do not always necessitate discontinuation of the medication. More severe symptoms associated with this condition include confusion, loss of vision, depression of mental status, hypothermia, respiratory failure, and low blood pressure. Recognizing this challenging clinical picture depends heavily on obtaining a thorough medical history, including medication use, as well as careful physical examination. A key aspect in diagnosing this condition relates to understanding toxicology principles, specifically the concept represented by the phrase cat mud piles. Although many consider the M to stand for metformin, it actually represents fenformin, which is an older drug related to metformin. This distinction is crucial when evaluating a patient with vague symptoms and a history of metformin use. It highlights the need to perform comprehensive testing, such as a full metabolic panel and venous blood gas analysis, to aid in accurate diagnosis. While fenformin was removed from the United States market in 1977 due to its association with life-threatening lactic acidosis, metformin is associated with this condition 20 times less frequently. Metformin-related lactic acidosis typically occurs in individuals with underlying conditions such as renal dysfunction. This increased risk is likely due to the greater tissue burden of metformin, which is eliminated by the kidneys. Other risk factors for metformin-associated lactic acidosis include cardiorespiratory insufficiency, septicemia, liver disease, a history of lactic acidosis, advanced age, alcohol abuse, and the use of radiologic contrast media. Iodinated contrast agents can cause acute renal dysfunction, leading to the accumulation of metformin and thereby increasing the risk of lactic acidosis. However, the overall risk of developing this condition after contrast administration remains low in patients taking metformin who have normal renal function and no other risk factors. The American College of Radiology recommends temporarily stopping metformin for 48 hours following the administration of intravenous contrast media if the estimated glomerular filtration rate is below 30 milliliters per minute per square meter. Lactic acidosis can also occur after an acute overdose of metformin, but such cases are uncommon. One case reported that metabolic acidosis was identified 14 hours after the overdose, with early symptoms including repeated vomiting occurring within the first hour after ingestion. A systematic review conducted by the Cochrane Library concluded that the therapeutic use of metformin does not increase the risk of lactic acidosis compared to other anti-diabetic treatments, provided there are no contraindications. However, this review did not assess the risk of lactic acidosis in scenarios involving overdose or renal dysfunction. The outcome following a metformin overdose can be difficult to predict. In one study, no deaths were observed in patients who had a serum pH greater than 6.9, a peak serum lactate concentration below 25 millimoles per liter, or a peak serum metformin concentration below 50 micrograms per milliliter. However, another study found no correlation between metformin concentrations and mortality in patients with metformin-associated lactic acidosis admitted to intensive care units. In that study, mortality was instead associated with elevated lactate levels and lower blood pH. Treatment recommendations for lactate accumulation and metabolic lactic acidosis involve several strategies. Clinicians should consider aggressive management of the airway and the use of vasopressor medications as needed based on the patient's condition. The administration of intravenous sodium bicarbonate can be considered. However, its use in critically ill patients with metabolic acidosis remains controversial due to uncertain benefits. In cases where standard treatments prove ineffective or the patient exhibits refractory acidosis, extracorporeal treatment methods are recommended. These therapies assist in removing lactate, pyruvate, and ketones from the bloodstream. Additionally, extracorporeal treatments serve as supportive therapy for uremia. It is important to note that even if the removal of the medication metformin is not fully adequate, clinical improvements can still occur. Such improvements are often attributed to the correction of the acid-base imbalance. Recently published recommendations from Workgroup 6 regarding extracorporeal treatment suggest using this approach when certain criteria are met. Specifically, extracorporeal treatment should be employed if the lactate concentration exceeds 20 millimoles per liter, the blood pH is less than or equal to 7.0, the patient presents with shock, standard supportive measures have proven ineffective, or the patient exhibits a decreased level of consciousness. Furthermore, these guidelines advise continuing extracorporeal treatment until the lactate concentration drops below 3 millimoles per liter and the blood pH exceeds 7.35. In the context of a metformin overdose, a period of observation lasting 4 to 6 hours is recommended. Usually, hospital admission is not necessary if the patient remains asymptomatic during this time and shows no signs of metabolic acidosis, elevated lactate levels, kidney dysfunction, vomiting, or hypoglycemia. Although hypoglycemia has been reported in some cases of metformin overdose, it is not clear whether metformin alone can induce this condition. Some experts believe that hypoglycemia associated with metformin occurs only in patients who also have metabolic acidosis. However, there have been reported instances of hypoglycemia following metformin overdose in patients without any mention of co-ingestants. Since many patients who use metformin also take medications like sulfonylureas, hypoglycemia should be anticipated after metformin overdose. It is important to note that metformin itself does not typically cause hypoglycemia either when used normally or in overdose circumstances. Sulfonylureas are a class of medications used in the treatment of type 2 diabetes. These drugs are often called insulin secretagogues because they stimulate the beta cells in the pancreas to release insulin. However, the effectiveness of the stimulatory effect tends to decrease with long-term use of these medications. Sulfonylureas mimic the effects of glucose on beta cells. Under normal circumstances, glucose enters the beta cells through transporter proteins called GLUT2 when blood glucose levels increase. Inside the beta cells, glucose is metabolized, which raises the levels of adenosine triphosphate, a form of energy. This increase in ADP binds to potassium ADP channels, causing them to close. When these channels close, the cell membrane depolarizes. This depolarization opens voltage-gated calcium channels, allowing calcium ions to flow into the beta cells. The rise in intracellular calcium then triggers the release of insulin that has been preformed within the cells. However, sulfonylureas bind to sulfonylurea receptors on the beta cells and cause the potassium ADP channels to close, bypassing the normal glucose sensing mechanism. As a result, these drugs force the beta cells to release insulin even when blood glucose levels are low, which can lead to an excessive release of insulin and potentially cause hypoglycemia. Taking a deeper look into the mechanism of sulfonylureas, these drugs enhance the effects of adenosine triphosphate at its sensor by binding to specific sites known as sulfonylurea receptors on the ADP-sensitive potassium channels. This binding prevents the efflux of potassium ions from the pancreatic beta cells. As a result, the closure of these potassium channels occurs, which raises the intracellular potential. This change further opens voltage-gated calcium channels, leading to an increase in intracellular calcium concentration through a cascade of phosphorylation reactions. The elevated calcium levels stimulate the release of insulin from the beta cells. Additionally, sulfonylureas may promote insulin release by binding to specific receptor sites on regulatory proteins involved in exocytosis and on insulin granule membranes. Furthermore, the hormone glucagon-like peptide, one plays a role in this process through its action on a G protein-coupled receptor, which increases cyclic adenosine monophosphate levels and enhances calcium-stimulated insulin secretion. Other factors contributing to hypoglycemia induced by sulfonylureas extend beyond their immediate effects on pancreatic beta cells. These extrapancreatic mechanisms are generally considered to be of little clinical significance. One such mechanism involves a reduction in hepatic gluconeogenesis, where sulfonylureas may decrease the liver's production of glucose. Additionally, these drugs might slow the breakdown and removal of insulin from the bloodstream, resulting in elevated insulin levels. Furthermore, sulfonylureas may increase the sensitivity of peripheral tissues to insulin, which can enhance the glucose-lowering effect of insulin throughout the body. Sulfonylurea-induced hypoglycemia can be prolonged, partly due to the long durations of action of many sulfonylureas. For example, second-generation sulfonylureas such as glympyride, glipizide, and glyburide have half-lives approaching 24 hours. First-generation sulfonylureas include acetohexamide, which has a half-life of 12 to 24 hours, chlorpropamide, with a half-life ranging from 24 to 72 hours, tolazamide, with a half-life of 10 to 24 hours, and talbutamide, which has a half-life of 6 to 24 hours. Second-generation sulfonylureas generally have longer durations of action, with glympyride exceeding 24 hours, glipizide lasting 12 to 24 hours, and glyburide remaining active for 18 to 24 hours. In addition to the long half-lives, the delayed onset of hypoglycemia following overdose of sulfonylureas can also contribute to prolonged episodes of low blood sugar. This delayed onset may be related to mechanisms that fail to respond adequately over time, such as counter-regulatory responses. Other factors influencing prolonged hypoglycemia include enterohepatic recirculation of the drugs, co-ingestion with other medications, and individual patient conditions, such as kidney dysfunction. Children who unintentionally ingest sulfonylureas should typically be hospitalized for 24 hours for observation due to the ongoing risk of delayed hypoglycemia. While dextrose is considered the immediate treatment for low blood sugar, its use in cases of sulfonylurea overdose requires careful consideration because of the potential for rebound hypoglycemia. Sulfonylureas work by stimulating the release of insulin even when blood glucose levels are low, which creates a challenging situation. The administration of dextrose can trigger further insulin release, leading to subsequent episodes of hypoglycemia. When addressing acute hypoglycemia caused by sulfonylurea overdose, rapid intravenous administration of dextrose is the most important measure. The primary goal is to raise serum glucose levels to a normal range, generally between 70 and 110 milligrams per deciliter. However, the extent of glucose elevation after dextrose administration is unpredictable and can vary significantly between individuals. A major concern with administering dextrose in this context is the risk of rebound or reactive hypoglycemia. This occurs because the initial increase in blood glucose can stimulate the pancreas to produce even more insulin, especially due to the ongoing effects of the sulfonylurea. Such a response can lead to a cycle of alternating high and low blood sugar levels, making treatment more complicated. Individuals with normally functioning pancreatic islet cells are particularly vulnerable to this rebound effect. There should be caution against the routine use of continuous dextrose infusion following the initial bolus. While continuous dextrose infusion may provide minimal caloric content, it may not effectively counter the rapid redistribution and utilization of glucose driven by excess insulin. Octreotide, a synthetic analog of somatostatin, is recommended for managing recurrent hypoglycemia in cases of sulfonylurea overdose because of its ability to inhibit insulin secretion. It works by blocking calcium entry through calcium channels, which directly suppresses insulin release from the pancreas. This mechanism helps counteract the effects of sulfonylureas, which stimulate insulin secretion. Octreotide is considered more favorable than diazoxide, another medication sometimes used to treat sulfonylurea-induced hypoglycemia, because diazoxide carries risks such as low blood pressure, cerebrovascular problems, and heart attacks. However, even when octreotide is used, careful monitoring for recurrent hypoglycemia remains essential, as the effects of sulfonylureas may last longer than the duration of octreotide administration. Prolonged monitoring and observation are crucial in cases of sulfonylurea overdose because hypoglycemia can occur in a delayed or protracted manner. The onset of hypoglycemia can vary widely, ranging from as early as 30 minutes to as late as 48 hours after ingestion. Children who unintentional ingest sulfonylureas are generally recommended to be hospitalized for at least 24 hours. Similarly, hospital admission is advised for individuals who intentionally overdose on sulfonylureas, regardless of initial blood glucose levels or the presence of symptoms. Key points to remember include the fact that dextrose is necessary for immediate treatment of hypoglycemia, but can also trigger rebound hypoglycemia in cases of sulfonylurea overdose. Close monitoring for recurrent episodes of hypoglycemia is vital even after initial stabilization. While octreotide is the preferred treatment to prevent rebound hypoglycemia, it does not eliminate the need for prolonged observation. The duration of monitoring should be tailored to each patient, considering factors such as the specific sulfonylurea ingested, the amount, the patient's age, and other relevant clinical factors. The standard dose of octreotide for managing recurrent hypoglycemia in adults experiencing a sulfonylurea overdose is 50 micrograms administered subcutaneously every 6 hours. The total duration of therapy with octreotide is typically suggested to be 24 hours. The rationale behind this dosage and administration involves its proven efficacy through clinical experience and multiple case reports, which demonstrate the effectiveness of this regimen in preventing recurrent episodes of low blood sugar following a sulfonylurea overdose. Octreotide is generally well tolerated at this dosage, with minimal side effects reported. From a practical standpoint, administering octreotide subcutaneously is less invasive and easier to manage compared to a continuous intravenous infusion. For pediatric patients, sources recommend an initial dose ranging from 1 to 2 micrograms per kilogram of body weight administered subcutaneously every 6 to 8 hours. The dosage can be increased up to the adult dose as needed. Arguments in favor of continuous infusion of octreotide include its ability to provide more sustained suppression of insulin secretion. This approach may help reduce the risk of rebound hypoglycemia, especially when managing the effects of sulfonylurea medications with a long duration of action or extended-release formulations. An infusion allows healthcare providers to adjust the dosage more flexibly based on the patient's response and the severity of the hypoglycemia. On the other hand, Administering a single dose of octreotide is generally easier and less invasive than establishing and managing an intravenous infusion. It can be more cost-effective, particularly if the patient responds well and does not need prolonged insulin suppression. Choosing between a single dose and an infusion of octreotide in cases of hypoglycemia caused by sulfonylurea involves careful consideration of these factors. While a single dose might be sufficient in some situations, an infusion can offer a greater safety margin, especially when there is a high risk of prolonged or recurrent hypoglycemia. It is crucial to monitor the patient closely to ensure proper glycemic control and to make appropriate treatment decisions as needed. The duration of action of octreotide when administered intravenously has a half-life ranging from approximately 72 to 98 minutes. However, its effect in inhibiting insulin secretion is estimated to last between 6 and 12 hours. In comparison, most sulfonylureas, except tolbutamide, have a duration of action exceeding 12 hours. Additional factors such as extended-release formulations, enterohepatic recirculation overdose, and the use of other drugs can further extend their effects. This difference in the duration of action has important clinical implications. Specifically, the effects of many sulfonylureas can outlast a single dose of octreotide. This prolongation increases the risk of recurrent hypoglycemia after the effects of octreotide have dissipated. Evidence from various studies and case reports supports these observations. A limited number of controlled trials have demonstrated that a single subcutaneous dose of octreotide at 75 micrograms can elevate blood glucose levels for the first 8 hours following administration. Nevertheless, some patients continued to experience hypoglycemia, indicating a recurrence despite the initial treatment. Furthermore, numerous case reports and case series have documented the use of octreotide for hypoglycemia caused by sulfonylureas. These reports vary in dosage and duration of treatment and frequently note that recurrent hypoglycemia can occur several hours after the last dose of octreotide. While insulin is generally considered a high-risk medication, its potential dangers in cases of overdose are particularly important to recognize. Hypoglycemia, or low blood sugar, remains a major concern associated with insulin use. Although poison control centers report more cases of accidental exposures to oral hypoglycemic medications than to insulin, the risk of hypoglycemia caused by insulin is significant. Up to 20% of patients taking sulfonylureas, another class of diabetes medications, experience hypoglycemia. In a study examining emergency hospitalizations for adverse drug reactions among adults over the age of 65, insulin was responsible for 14% of these admissions. Notably, 95% of the hospitalizations related to insulin use were caused by hypoglycemia. This data underscores the importance of cautious insulin management, especially in vulnerable populations. Toxicokinetic features contribute to prolonged hypoglycemia following insulin overdose. This condition can result from the pharmacokinetic properties of certain insulin preparations, which include a slow onset of action and an extended duration. Even insulin formulations designed for short-acting effects can cause unexpected episodes of hypoglycemia due to several factors. One such factor is the depot effect, where insulin administered into the subcutaneous or muscle tissue forms a depot that is slowly absorbed into the bloodstream. Additionally, hypoglycemia itself can impair insulin absorption by reducing blood flow to the injection site, further complicating the situation. Although higher doses of insulin do not necessarily cause more severe hypoglycemia once the insulin receptors are saturated, they can extend the duration of hypoglycemic episodes. The severity of insulin overdose cannot be reliably predicted solely based on the dose or the type of insulin preparation used. Some individuals have died after taking doses in the hundreds of units, while others have survived doses reaching into the thousands. Mortality and morbidity are more likely to be related to factors such as the delay in recognizing hypoglycemia, the duration of symptoms, the time taken to initiate treatment, and the development of complications. Recurrent hypoglycemia is a significant concern following an insulin overdose, even after initial treatment with intravenous dextrose. Studies have shown that this condition can recur, with one research finding that 41% of patients experienced episodes of low blood sugar within 5 to 39 hours despite receiving oral feeding and continuous dextrose infusions. These findings emphasize the importance of close monitoring and proactive management strategies to prevent and address recurrent hypoglycemia effectively. The primary goal in treating an insulin overdose is to rapidly correct hypoglycemia by increasing blood glucose levels. This is typically achieved through the administration of hypertonic intravenous dextrose solutions, with doses adjusted for age groups, such as dextrose 50% in water for adults, dextrose 25% in water for children, and dextrose 10% in water for neonates. Once the patient's blood glucose levels are stabilized, the focus shifts to maintaining normal glucose levels and preventing recurrent episodes of hypoglycemia. This can be challenging because administering dextrose may stimulate insulin release in patients with an intact pancreatic function, potentially creating a cycle of hypoglycemia followed by hyperglycemia. For patients with diabetes who have accidentally taken too much insulin but are not experiencing severe neuroglycopenia, dietary management is recommended. This includes feeding the patient carbohydrate-rich foods and proteins, along with close monitoring. It is also advised to avoid routine infusions of dextrose in these cases. In cases of recurrent hypoglycemia, especially following overdose with certain medications, the use of agents such as octreotide may be considered. These agents stimulate the release of insulin, which can be particularly useful in overdose cases involving medications that stimulate insulin secretion, such as sulfonylureas or meglitinides. Octreotide is a synthetic analog of somatostatin, a hormone that inhibits insulin secretion. Although there is limited evidence specifically supporting its use for insulin overdose, it is likely effective in managing recurrent hypoglycemia following overdose with any non-insulin anti-diabetic medications. Hospital admission is indicated in several scenarios. These include hypoglycemia related to sulfonylureas, alcohol consumption, starvation, liver failure, kidney dysfunction, or unknown causes. Admission is also necessary after unintentional overdose with long-acting insulin and in cases of persistent or recurrent hypoglycemia following overdose with short-acting or intermediate-acting insulin. Additionally, hospital care is warranted in cases of intentional overdose with any form of insulin or when there is suspicion of self-induced hypoglycemia. C-peptide is a valuable marker in diagnosing hypoglycemia because it helps distinguish between hypoglycemia caused by endogenous insulin production and hypoglycemia caused by exogenous insulin administration. Insulin is produced in the pancreas by beta cells as part of a larger molecule called proinsulin. This proinsulin is then cleaved into insulin and C-peptide, which are released into the bloodstream in equal amounts. While insulin is the biologically active component, C-peptide has no known biological activity. It is important to note that the liver clears insulin from circulation, but it does not clear C-peptide. This difference makes C-peptide a reliable indicator of endogenous insulin production. When a patient presents with low blood sugar levels, measuring the levels of C-peptide can assist in identifying the underlying cause. If the hypoglycemia is caused by the injection of external insulin, the levels of insulin in the blood will be high, but the C-peptide levels will be low or suppressed. This occurs because the body does not produce the injected insulin, and therefore no C-peptide is released alongside it. In contrast, if the hypoglycemia results from the body's own insulin production, such as from a tumor that secretes insulin, both insulin and C-peptide levels will be elevated when blood sugar is low. This indicates that the insulin is being produced endogenously. Another possible cause is overdose of a medication called sulfonylurea, which stimulates the pancreas to release excessive amounts of insulin. In cases of overdose, both insulin and C-peptide levels will be high, mimicking the pattern observed in patients with insulin-secreting tumors. Understanding these patterns helps clinicians determine the root cause of hypoglycemia and guide appropriate treatment strategies. Both insulinoma and overdose of sulfonylurea can result in elevated levels of insulin and C-peptide. To distinguish between these two conditions, additional tests are often necessary. Laboratory analysis can detect the presence of sulfonylurea metabolites in the urine, which confirms an overdose of this medication. Another useful diagnostic approach is the insulin suppression test, which involves administering octreotide, a medication that reduces insulin secretion. In cases of insulinoma, insulin levels will remain high despite the administration of octreotide. Conversely, in cases of sulfonylurea overdose, insulin levels will decrease after the medication is given. When evaluating a patient who presents with fasting hypoglycemia, laboratory tests of specific markers are crucial for determining the underlying cause. One particularly useful marker is the C-peptide, which helps distinguish whether hypoglycemia is due to the body's own insulin production or the administration of external insulin. Both insulin and C-peptide are secreted together in equal amounts by the pancreatic beta cells. However, unlike insulin, C-peptide is not cleared by the liver, making it a reliable indicator of endogenous insulin production. In cases of hypoglycemia caused by external insulin administration, serum insulin levels are typically very elevated. Conversely, C-peptide levels are low or suppressed, indicating that the excess insulin is coming from an outside source rather than the patient's own pancreas. Often, insulin-binding antibodies are present, and there will be no detection of sulfonylurea metabolites. If hypoglycemia is due to an insulin-producing tumor of the pancreas, known as an insulinoma, both serum insulin and C-peptide levels will be elevated during episodes of hypoglycemia. Insulin-binding antibodies are usually present in these cases, but sulfonylurea metabolites are absent. In instances where hypoglycemia results from ingestion or overdose of sulfonylurea medications, which stimulate the pancreas to release large amounts of insulin, both serum insulin and C-peptide levels will be high. This pattern is similar to that seen with insulinomas. The key distinguishing factor is the presence of sulfonylurea metabolites detected in urine tests, which confirm the overdose. Insulin-binding antibodies can also be found in these cases. Autoimmune hypoglycemia involves the presence of antibodies that target insulin or related components, leading to abnormal insulin activity. Serum insulin levels can appear very high, and C-peptide levels may be either low or high, often reflecting artifacts. Insulin-binding antibodies are present, and sulfonylurea metabolites might also be detected. When hypoglycemia is caused by decreased glucose production, such as in severe liver disease or critical illness, both serum insulin and C-peptide levels are typically low. In these cases, insulin-binding antibodies may be present, but sulfonylurea metabolites are absent. Similarly, hypoglycemia due to certain non-beta cell tumors involves low levels of serum insulin and C-peptide. These cases often involve the presence of insulin-binding antibodies, while sulfonylurea metabolites are not detected. Understanding these diverse laboratory profiles is essential for accurate diagnosis and effective management of patients experiencing hypoglycemia. The strategic combination of measuring C-peptide, insulin levels, and specific drug screening such as sulfonylurea metabolites allows clinicians to precisely identify the cause and tailor appropriate treatment strategies. Hypoglycemic agents are drugs used to manage hypoglycemia, which requires immediate treatment with intravenous dextrose to quickly raise blood glucose levels. Close monitoring for recurrent hypoglycemia is essential, and the use of octreotide is highly recommended because of its ability to inhibit insulin secretion and prevent rebound hyperinsulinemia. Lactic acidosis associated with certain medications, sometimes referred to as medication-associated lactic acidosis, involves complex mechanisms with unclear causes. It can be related to overdose, renal dysfunction, or even therapeutic use within normal dosing ranges. Supportive care, including measures like intravenous fluids and organ support, remains the mainstay of treatment. In cases where acidosis is refractory, extracorporeal elimination techniques, such as hemodialysis, can be considered. Sulfonylureas are drugs that stimulate insulin secretion by binding to receptors on pancreatic beta cells. This action causes the closure of potassium channels and subsequently leads to increased insulin release. Overdose of sulfonylureas can cause hypoglycemia, which is often prolonged and may have a delayed onset. The duration of hypoglycemia is related to the dose and can last for several days. The risk of hypoglycemia increases with agents that have longer half-lives, although the duration of their action does not always directly correlate with their elimination half-lives for reasons that are not fully understood. Insulin, a hormone used in the treatment of diabetes, can also cause severe and prolonged hypoglycemia. The severity of hypoglycemia depends not only on the dose or type of insulin used, but also on factors like delayed recognition of symptoms, prolonged symptoms, and late initiation of treatment. Recurrent episodes of hypoglycemia pose a significant concern even after initial management, emphasizing the need for careful monitoring and prompt intervention.
This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.